Coagulation, CLSR. Platelets, production. Produced from megakaryocytes. Distributed 30% from the spleen, 70% from the peripheral blood. Reference range 150 to 400,000 per millimeter cubed. They live from 9 to 12 days. Functions: initial arrest of bleeding and formation of the platelet plug. Adhesion: glycoprotein 1b binds to exposed collagen. Requires von Willebrand factor. Results in release or secretion of ADP and other granule components, including factor V and fibrinogen. Aggregation: other platelets are stimulated by ADP and undergo shape change, disc to sphere to pseudopods, exposing the glycoprotein 2b3a complex, which binds fibrinogen. This is the complex that is blocked by a number of glycoprotein 2b3a inhibitor drugs. Fibrinogen binding links the platelets, the first and reversible phase of aggregation. With weak stimuli, the aggregates can dissociate, but strong stimuli cause the aggregating platelets to release or secrete. With release, the aggregation is irreversible. After adhesion and aggregation, a platelet plug is built at the injury site. The PFA test asks the important question: do the platelets properly adhere and aggregate at the injury site? Localization of the platelet plug. Secreting platelets release arachidonic acid, which converts to prostaglandin, which becomes thromboxane A2 in the platelet. Arachidonic acid is processed by adjacent endothelial cells to form platelet-inhibiting prostacyclin. So the platelet plug is limited to the injury site. Assembly and localization of the fibrin clot. Platelet release components include fibrinogen, factor V, and factor VIII. Fibrinogen is bound on the platelet surface during aggregation. Factor VIII is bound to the platelet surface with von Willebrand factor. Shape change exposes platelet membrane phospholipid, PL, the template for the assembly of the factor complexes. Historically called platelet factor III, binds the factor VIII and 9A complex, requires calcium 2+. No wonder hemophilia A and hemophilia B, factor VIII and 9 deficiencies, are clinically identical. Binds the factor V and 10A complex, also requires calcium 2+. The platelet plug is a wonderful place to produce a fibrin clot, and without the platelet presence, the fibrin won't form. It is clot promotion and clot localization all in one. Plasma coagulation factors. Functions. Factor I, or fibrinogen, is the substrate. The cofactors accelerate enzymatic reactions. Factors 3, 5, and 8, and factor HMWK, high molecular weight kininogen. Enzymes are serine proteases, which cleave peptide bonds, factors 2, 7, 9, 10, 11, and 12, and transamidase, factor 13 only. Characteristics of coagulation proteins. The contact group of factors, factor 11, 12, PK, and HMWK. The prothrombin group of factors is factor 2, factor 7, factor 9, and factor 10. They are vitamin K dependent, and factor 2 is consumed in clotting. The fibrinogen group of factors is factor 1, 5, 8, and 13, and they are all consumed in clotting. The contact proteins, factors 12, 11, PK, and HMWK, all participate in the initial phase of the intrinsic system. They are not consumed during clotting. They are both found in serum and plasma, and they're not vitamin K dependent. The prothrombin proteins, factors 2, 7, 9, and 10, are vitamin K dependent, and they are not consumed during clotting except factor 2. They are present in fresh and stored plasma and serum. The fibrinogen proteins, factors 1, 5, 8, and 13, are all consumed during clotting and therefore not found in serum. They increase in acute phase, pregnancy, and inflammation. The factor names are all notated by Roman numerals except prekallikrein and high molecular weight kininogen. Stabilized cross-linked fibrin. It's activated intrinsically by the collagen via factor 12 contact system. Activated extrinsically by disrupted endothelial cell membrane, tissue factor, or tissue thromboplastin. Complex with factor 7 to directly activate factor 10. Cofactors. Factor 8 is bound with activated factor 9 by calcium to the platelet phospholipid membrane. Together, these factors activate factor 10. In the common pathway, factor 5 is the cofactor to factor 10A in a similar arrangement with calcium and PL. This prothrombinase complex converts prothrombin to the active thrombin. Thrombin cleaves peptides off of the fibrinogen molecule to form fibrin, which polymerizes to form insoluble fibrin strands. Thrombin also activates factor 8, which cross-links the fibrin strands at the D region, which is the birth of the D dimer. Other functions of thrombin: feeds back to potentiate factors 5 and 8, recruits and aggregates platelets, turns on endothelial thrombomodulin receptor or activator for protein C and protein S system to inactivate factors 5 and 8. Heparin sulfate on the endothelial cell binds antithrombin, which inactivates the activated serine proteases. Heparin also works this way. Activated protein C and its cofactor protein S, when bound to its receptor or activator thrombomodulin, inactivates factors 8 and 5. Fibrinolytic system. Activated intrinsically by collagen via the factor 12 contact pathway that initiates intrinsic clotting, or extrinsically by tissue plasminogen activator, or TPA. Activators convert the precursor plasminogen to plasmin. Plasmin cleaves fibrin strands to soluble fragments of fibrin. Fibrin degradation products are X, Y, D, or E. Can come from fibrin clot, or fibrinolysis, or from unclotted fibrinogen, fibrinogenolysis. D dimer comes from cross-linked clot, or clot-specific. TPA inactivated by tissue plasminogen activator inhibitor, which stops activation. Active plasmin inhibited by alpha-2 plasmin inhibitor if it escapes the area of the clot. This prevents fibrinogenolysis. Excessive and inappropriate fibrinolysis is a major feature of disseminated intravascular coagulation, or DIC, response to excessive clotting. Also seen in liver disease, activators are not cleared and the inhibitors are diminished. Complications of cancer or surgery of the prostate or urinary tract where urokinase can leak into the circulation. Clot busters are streptokinase, which is commercial, urokinase, which is commercial, and tissue plasminogen activator, which is commercial and in vivo. Specimen collection and handling. Sodium citrate 3.2%. Calcium 2+ is necessary for both coagulation and platelet aggregation studies. Whole blood, anticoagulant ratio 9:1. Use plastic tubes or siliconized glassware. Glass activates factor 7 and platelets will adhere to glass. Coagulation samples can now be drawn first when using evacuated tubes or vacutainers. Historical reports of contamination with tissue thromboplastin during collection are unfounded. Hemolyzed samples should not be used for platelet aggregation studies. Red cells contain ADP. Lipemic samples may cause problems with coagulation and aggregation studies, may obscure changes in optical density. Prothrombin time, or PT. Screen for extrinsic and common pathways. Measures factors 1, 2, 5, 7, and 10. Monitors oral anticoagulants, warfarin, coumarin, and dicumarol. Reagent, tissue thromboplastin, and calcium dichloride. Sensitive to vitamin K factors. International Normalized Ratio, or INR. INR equals the patient results over the mean of reference range raised to ISI. ISI is the International Sensitivity Index from the manufacturer. The reference range for PT is under 13 seconds. The therapeutic goal is INR 2 to 3.5. Activated partial thromboplastin time, APTT. Screen for intrinsic and common pathways. Measures all factors except factor 7 and 13. Monitors heparin therapy. Reagents. Activator, kaolin, selite or ellagic acid, platelet phospholipid, and calcium dichloride. The reference range for activated partial thromboplastin time is 20 to 40 seconds, and the therapeutic goal is 1.5 to 2.5 times the normal, or use heparin response curve. Fibrinogen assay. Quantitative measure of factor 1. Reference range 200 to 400 milligrams per dl. Thrombin time. Does not measure defects in intrinsic or extrinsic pathways. Affected by decrease of fibrinogen levels and presence of heparin and other antithrombins. The reference range is under 20 seconds. Bleeding time. Historically measured platelet function and numbers, but generally replaced by PFA. Platelet function assay, or PFA test. Measures platelet function with collagen, ADP, and epinephrine. Sensitive to aspirin, von Willebrand's disease, and ADP receptor problems. Replaces the bleeding time as a screen. Clot retraction. Evaluates platelet function, fibrinogen, red cell volume, and fibrinolytic activity. Abnormal if patient count is under 100,000 per millimeter cubed. Anemia and hypofibrinogenemia decrease clot retraction. Rapid dissolution of clot indicates increased fibrinolytic activity. Example, DIC. Glanzmann's thrombasthenia, no clot retraction. Special tests of hemostatic function. Platelet aggregation, necessary for platelets to stick to each other. In vivo aggregating agents. ADP, collagen, epinephrine, thrombin, serotonin, arachidonic acid, ristocetin, snake venom, antigen-antibody complexes, and fibrin degradation products. In vitro aggregating agents: ADP, collagen, ristocetin, epinephrine, thrombin, arachidonic acid. Platelet aggregation is measured with photo optics. As platelets aggregate, the turbidity of platelet-rich plasma decreases. Samples kept at room temperature heated to 37 Celsius prior to testing. Stirring necessary to bring platelets in contact for aggregation to occur. Aspirin inhibits secondary wave of aggregation, destroys cyclooxygenase. Abnormal ristocetin-induced aggregation, Bernard-Soulier and von Willebrand. In Glanzmann, only ristocetin works. Assays are abnormal aggregation, all agents are decreased, but von Willebrand is normal. Bernard-Soulier, thrombin doesn't work, decreased or moderate decrease of something, giant platelets, and abnormal adhesion or ristocetin decreases. Von Willebrand factor normal. Von Willebrand's, usually normal platelet number, normal morphology, abnormal adhesion or ristocetin decrease, von Willebrand factor abnormal. Factor assays: PT and APTT tests performed with specific factor deficient plasma. Percent activity and amount of correction with normal plasma determined. Range 40 to 150% normal. Dilute Russell's viper venom test. Activates factor 10 in presence of reduced phospholipids. Prolonged in presence of lupus anticoagulant. Von Willebrand's disease has normal platelets, decreased factor 8, decreased von Willebrand factor. Bernard-Soulier has giant platelets. Anti-factor 10A assay. Monitors low molecular weight heparin therapy, or LMWH, and other anti-10A oral anticoagulants. The APTT is insensitive to LMWH. Reptilase time. Snake venom enzyme. Test similar to prothrombin time, but is not inhibited by heparin. Good to use for patients on heparin. The reference range is 18 to 22 seconds. Fibrinolysis testing. Fibrin and fibrinogen degradation, or split products, FDP or FSP. Latex beads coated with anti-fibrinogen. Historical use as positive screen in DIC. Latex D-dimer, monoclonal antibody to cross-linked D fragment, positive in DIC, deep vein thrombosis, and pulmonary embolism. Quantitative D-dimer has negative predictive value to rule out thrombotic events. Intraoperative point-of-care testing, testing to support highly invasive and high-risk surgeries. Impedance aggregometry, whole blood method of aggregation, measures electrical impedance changes as platelets aggregate on electrodes. Thromboelastometry, measures timing and elastic properties of the clot through the process of formation. Different reagents and agonists test various hemostatic pathways. Hemostasis disorders. Inherited disorders. Hemophilia A, deficiency of factor 8, sex-linked recessive, almost exclusive to men. Spontaneous bleeding into joints. Treat with commercial factor 8. Hemophilia B, deficiency of factor 9, sex-linked recessive, almost exclusive to men. Clinically identical in inheritance and symptoms to hemophilia A. Treat with factor 9 concentrates. Hemophilia C, deficiency in factor 11, incomplete autosomal recessive, wide range in clinical severity, high incidence in Ashkenazi Jews. Only contact factor associated with bleeding. Von Willebrand disease. Primary defect in the von Willebrand disease, or VWF. VWF binds platelets via the glycoprotein 1BV9 receptor. Usually find secondary deficiency of factor VIII. Autosomal dominant. Males and females are affected equally. Platelet adhesion defect with abnormal PFA test. Treat with cryoprecipitate or DDAVP. Factor VIII concentrates do not contain von Willebrand factor. Factor XIII deficiency. Autosomal recessive. Not detected by common coagulation tests. Results in a significant bleeding disorder. Poor wound healing. Detected with the 5M urea test. Acquired disorders. Inhibitors. Usually IgG antibody directed against a specific factor or phospholipids. Lupus anticoagulant, directed against phospholipids. Seen in lupus erythematosus, about 5 to 10%, but also seen in malignancies, infections, drug therapy, and other autoimmune disorders. Screening tests use low concentration phospholipid reagents, e.g., DRVVT. Use platelet neutralization techniques to confirm presence. Phospholipid neutralizes antibody and test will correct. Can prolong the APTT. Predisposes patient to clotting. Factor VIII inhibitor. Most common specific inhibitor, but others have been demonstrated. APTT mixing studies differentiate factor deficiency from inhibitor. If corrected by normal plasma, a factor deficiency is indicated. If not corrected, an inhibitor should be investigated. Vitamin K deficiency. Functional deficiency of factors 2, 7, 9, and 10. PIVKA molecules or proteins in vitamin K absence, present but not functional. Vitamin K originates from diet and bacteria in gut. Deficiency seen in poor diet and with broad-spectrum antibiotic use. Same result observed in warfarin therapy. Liver disease, depending on severity or stage. Deficiency of factors 1, 2, 5, 7, 9, and 10. Factor 7 deficiency most pronounced. Decreased clearance of plasminogen activators. Increased FDP due to fibrinogen disseminated intravascular coagulation, or DIC. Secondary to sepsis, obstetric complications, Ebola virus infection. Thrombotic occlusion of microcirculation, red blood cell fragments. Consumption of platelets and factors 1, 5, and 8. High levels of FDP and D-dimer. Thrombotic diseases. Arterial events. Platelet-driven arteriosclerosis. Prosthetic heart devices. Venous events. Blood flow problems, superficial or deep vein thrombosis. Clot inhibitor deficiency, about 20%. Antithrombin, formerly AT3. Principal antagonist of active coagulation proteases. Produced in the liver. Activated by heparin sulfate on the endothelial cell and by heparin as therapeutic drug. Protein K. Vitamin K-dependent serine protease. Activated by thrombomodulin on the endothelial cell. Requires protein S cofactor. Inactivates factors 5 and 8. Protein S. Vitamin K-dependent. Cofactor for protein C. Bound and free state. Only free protein S is functional, so measure total and free. Factor V Leiden. Mutant factor 5. Resists the action of protein C and S. Activated protein C resistance test. Antiphospholipid syndrome. Any of 3 classes of antibodies. Anticardiolipin antibodies, Lupus anticoagulant. Specific antibodies, e.g. beta-2 glycoprotein. Prothrombin mutation. Mutation at position 2021-0. First described in 1996. 1 to 2% of general population are heterozygotes. Results in increased thrombin formation, increased risk of thrombotic event. Anticoagulant therapy. Platelet inhibitors. Aspirin destroys cyclooxygenase to inhibit release reaction. Affected platelets are inhibited permanently until replaced. Clopidogrel, or Plavix, blocks the ADP receptor P2Y12 and is also permanent until platelet is replaced. Glycoprotein 2B3A receptor inhibitors. Abcicimab, eptifibatide, and tirofiban, not permanent. Oral plasma protein anticoagulants. Warfarin prevents production of functional factors 2, 7, and 9, and 10 by inhibiting vitamin K. Requires monitoring using PT-INR. Prothrombin inhibitor, or dabigatran, requires no monitoring. Factor 10A inhibitors, rivaroxaban and apixaban, generally require no monitoring. Paraenteral anticoagulants. Heparin, unfractionated. Inhibits the active serine protease factors via antithrombin. Usually monitored with the APTT using a heparin response curve. Can also be monitored using anti-10 assay. Low molecular weight heparin, or LMWH, targets factor 10A, yields a more predictable response than unfractionated heparin. Does not usually require monitoring, but if needed, monitor with the anti-factor 10A assay. Coagulation CLSR sample questions. 1. If one performs an APTT on a patient on high-dose warfarin therapy, we would expect that the result would be increased because of other multiple factor deficiencies. The prothrombin time is used to monitor warfarin therapy, but warfarin results in deficiencies of factors 2, 7, 9, and 10. 2. Abnormal PFA results and giant platelets best describe Bernard-Soulier syndrome. Glanzmann's thrombasthenia and von Willebrand disease have normal platelet morphology, even though the bleeding time is prolonged. Wiskott-Aldrich syndrome have tiny platelets and a prolonged bleeding time. 3. A 7-year-old male child is a candidate for ear tube surgery because of repeated ear infections, but he has a persistent prolonged prothrombin time. The APTT is normal. Which condition is most likely? Vitamin K deficiency is most likely because of the presentation. The child is likely treated with repeated courses of antibiotics, which kills vitamin K producing organisms. Congenital deficiencies are extremely rare since inheritance is autosomal recessive. Hemophilia A yields a normal PT and prolonged APTT, and factor V Leiden causes neither. 4. A 22-year-old woman was seen in the emergency room with evidence of bleeding following a spider bite. Laboratory results show schistocytes on the blood smear, 50,000 per millimeter cubed platelets, a 20-second PT, a 60-second APTT, and a positive D-dimer. The most likely diagnosis is secondary fibrinolysis. Allergies do not result in coagulation abnormalities. Primary fibrinolysis would not show schistocytes or decreased platelets or a positive D-dimer test. And vitamin K deficiency is not characterized by schistocytes or a positive D-dimer test. 5. A 4-year-old male has a prolonged APTT of 53 seconds. Mixing with normal plasma at a ratio of 1:1 yields an APTT of 50 seconds. The 1-to-1 mix is still abnormal, so the mixing study indicates a strong anticoagulant or inhibitor. In both hemophilia A and B, a 1-to-1 mix would correct the condition. It's not SLE or systemic lupus erythematosus because the patient may have a lupus anticoagulant, but that does not mean he has SLE. A small number of patients with SLE exhibit the lupus anticoagulant, but it is also seen in many other conditions.